Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. So I welcome you to part 82 of our MCQ pharmacotherapy series, Measuring in Basic Oncology. Question number 1 reads, Mrs. PWN, a 26-year-old female patient, presents to her gynecologist's clinic for her follow-up checkup. My question to you is, which of the screening recommendations for cervical cancer listed below would be the most appropriate for Madam PWN's case now? Would it be cytology and HPV screening every 5 years? Or would it be cytology alone every 3 years? Or would it be cytology and HPV testing every 3 years? Or would it be cytology alone annually? I'll give you 10 seconds to choose the correct answer. So cytology alone every 3 years would be the recommended one. Now the NCCN guidelines endorse the American Cancer Society, the American Society for Colonoscopy and Cervical Pathology, and even the American Society for Clinical Pathology screening guidelines for the prevention of and early detection of cervical cancer. And according to all those guidelines, patients between the ages of 21 and 29 years should undergo cytology alone, that's the pap smear, every 3 years. I would like to add that women shouldn't be screened annually at any age with any method, and recommendations should be based on the patient's age and clinical history. And I would like to emphasize that HPV testing shouldn't be used for screening in patients between the ages of 21 and 29. Now, while patients may test positive for HPV, most episodes of HPV infection are transient and will not develop into cervical cancer. Furthermore, false positive results may lead to unnecessary tests and procedures, so avoid them. Now, every 5 years isn't an appropriate screening interval for patients between the ages of 21 and 25 at all. I would like to emphasize that cervical cancer screening should begin at the age of 21 years, and women of age below 21 years shouldn't be screened regardless of their age of sexual initiation or debut, or even other risk factors. That's just by the way for your information. Let's move to the next question, please. And it reads, leucovorin is a reduced form of folic acid with utility in various settings of cancer patients. My question to you is, which of the statements listed below best describes the utility of leucovorin? Is it true that leucovorin helps rescue from the toxicity of 5-fluorouracil? Or is it true that leucovorin helps rescue from the toxicity of methotrexate? Or is it true that leucovorin helps modulate the activity of capecitabine? Or is it true that leucovorin helps modulate the activity of oxaliplatin? I'll give you 10 seconds to choose the correct answer from that list of 4 options? So leucovorin helps rescue from the toxicity of methotrexate. Now I'd like to begin by saying that high-dose methotrexate is lethal unless administered with leucovorin rescue. Remember, methotrexate inhibits dihydrofolate reductase and ends up depleting reduced folates, while leucovorin, on the other hand, restores these depleted stores, thereby enabling DNA synthesis in the process. Now, leucovorin is commonly used in acute lymphoblastic leukemia patients who are receiving high-dose methotrexate. And leucovorin modulates the activity of 5-fluorouracil by helping to potentiate the inhibition of what we call thymidylate synthase. Now, capecitabine is the prodrug of 5-fluorouracil, but leucovorin administration isn't recommended when treating patients with capecitabine. And I would just like to add that leucovorin helps rescue methotrexate-induced toxicities, but can also be used synergistically with 5-fluorouracil with an intention of potentiating its effects. Now, in the event of leucovorin shortage, which can occur, levothyroxine can be used to replace leucovorin, and the dose of levothyroxine is equivalent to 50% the standard dose of leucovorin. So just be aware of that. If you are hit by hitches in the supply chain, you could opt to procure and use levothyroxine at 50% the standard leucovorin dose. Let's move to the next question, please. And it reads, Mrs. AWK, a 43-year-old female patient with confirmed acute lymphoblastic leukemia, abbreviated as ALL, undergoes induction chemotherapy at your oncology clinic, shortly after which she develops aspergillus lung infection, an OI. She is day +2 after matched unrelated donor hematopoietic stem cell transplant. So my question to you is, which of the options listed below would be the most appropriate for antifungal prophylaxis in Madam AWK's case now? Would it be posaconazole, voriconazole, micafungin, or fluconazole? I'll give you 10 seconds to choose the best answer. Voriconazole it would be. Now, fluconazole has no activity whatsoever against aspergillus, that's the mold infections, so it would not be the best option here. Then posaconazole has been shown to have a better efficacy compared to fluconazole. It may be a better agent against mold infections like zygomycetes. Then I'd like to emphasize that voriconazole is a better choice in Madam AWK's case, as in patients with prior aspergillus infection. It has been shown to provide benefit, and it's available in both IV and oral formulations. Remember, some of these patients may not be able to take medication orally. So the advantage with voriconazole is that you can administer it via both routes. Now, the echinocandins like micafungin and caspofungin demonstrate efficacy, but breakthrough infections are a major concern when they're used in patients like this particular lady, AWK. So I would settle for B, voriconazole. Let's move to the next question, please. And it reads, with which of the following agents are adverse effects like fever, pulmonary infiltrates, acute respiratory distress, pulmonary capillary leakage, and weight gain associated? Is it with nilotinib, marketed as Tasigna? Is it with tretinoin, marketed as Vesanoid? Or is it with busulfan, marketed as Myleran? Or is it with hydroxyurea, marketed as Hydrea? I'll give you 10 seconds to choose the correct answer. So B would be the best answer. Now, tretinoin or all trans-retinoic acid derivatives can produce these effects, which are called differentiation syndrome in literature. Now, patients may present with fever with an elevated W cell count, WBC, greater than 10 times 10 power 9 per liter. Shortness of breath, weight gain can occur, hypoxia may be observed, even pleural and pericardial effusions can be observed, and they've been reported in clinical scenarios such as this one. Now, treatment of differentiation syndrome requires dexamethasone 10 milligrams IV administered twice daily for 3 to 5 days, followed by a tapering over 2 weeks. Now, temporary cessation of tretinoin is prudent in patients with significant hypoxia. So don't continue pumping tretinoin without taking care. The situation may deteriorate. Let's move to the next slide, please. The next question reads, supply chain hitches have resulted in a shortage of leucovorin in your hospital, and your oncology team decides to switch all patients receiving leucovorin to level leucovorin. So my question to you is, for a patient receiving 400 milligrams per meter squared of leucovorin, what would be the appropriate level leucovorin dose? Would it be 800 milligrams per meter squared of level leucovorin, or would it be 100 milligrams per meter squared of level leucovorin, or would it be 200 milligrams per meter squared of level leucovorin, or D, would it be 400 milligrams per meter squared of level leucovorin? I'll give you 10 seconds to choose the correct answer. So I would dose level leucovorin at 200 milligrams per meter squared. Now, a dose of 200 milligrams per meter squared of level leucovorin is equivalent to 400 milligrams per meter squared standard leucovorin. Now, in many times of shortage, like in the US, for example, patients can be switched from leucovorin to level leucovorin, which is commonly used in the European countries. The dose of level leucovorin is equivalent to 50% of the dose of standard leucovorin. Remember that. Now, the NCCN guidelines recommend several options for overcoming leucovorin shortage, especially in the US, such as switching to level leucovorin, using lower doses of leucovorin in all patients, because from studies it has been shown to be efficacious, as efficacious as higher doses based on colorectal cancer studies specifically, which were done in the US. You can also opt to give fluorouracil without leucovorin, which requires a modest increase of around 10% in the fluorouracil dose for patients who can tolerate the higher doses without significant toxicity. Just as a by the way, let's move to the next question, please. The next question reads, Mr. POC, a 57-year-old male patient with confirmed metastatic colon cancer, is being initiated on FOLFIRI, which is fluorouracil, irinotecan, alongside leucovorin. During his first night of chemotherapy, he experiences severe abdominal cramping and diarrhea. So my question to you is, which of the treatments listed below would be the most appropriate for Mr. POC now? Would you opt to administer tincture of opium, atropine, loperamide, or octreotide? I'll give you 10 seconds to choose the correct answer. So I would choose to administer atropine. Now, we know that irinotecan can cause both acute and delayed diarrhea. Now, acute diarrhea occurs immediately after irinotecan administration and is usually associated with cholinergic symptoms such as abdominal cramping, which is described in the above case. Rhinitis can occur, lacrimation, and even salivation. Now, the mean duration of these symptoms is 30 minutes, and atropine is the drug of choice in such a clinical scenario. I would like to emphasize that Mr. POC has acute diarrhea because we know that the onset is less than 24 hours after the administration of irinotecan. I would just like to emphasize that delayed diarrhea occurs more than 24 hours after irinotecan administration. It's usually non-cumulative and it occurs at all dose levels. Now, octreotide, loperamide, and tincture of opium are inappropriate for Mr. POC since they don't have any anticholinergic properties and they won't relieve this gentleman's symptoms at all. Now, risk factors for irinotecan-induced diarrhea include weekly administration, poor performance status, high serum creatinine levels, prior abdominal radiation therapy, low WBC, and even age above 70 years, and even the presence of Gilbert syndrome and what we call the Crigler-Najjar syndrome type 1. In literature, they quote those as the major risk factors, just for your information. Let's move to the next question, please. And it reads, Mr. GSO, a 23-year-old man, received an allogeneic hematopoietic stem cell transplant. His conditioning chemotherapy consisted of cyclophosphamide and busulfan. He is currently receiving methotrexate and tacrolimus for graft versus host disease prophylaxis. So my question to you is, which of the monitoring parameters listed below would be the most ideal for Mr. GSO's immunosuppressive medications? Would it be the PFTs, hepatic panel, and potassium levels, or would it be hepatic panel, serum creatinine, and potassium levels, or would it be an echocardiogram, a urinalysis, and albumin levels, or would it be urinalysis, a platelet count, and PFTs? I'll give you 10 seconds to choose the correct answer. I would settle for hepatic panel, serum creatinine, and potassium levels. I would like to start by saying that tacrolimus, which is marketed as Prograf, can increase the risk of renal toxicity, hepatotoxicity, electrolyte wasting, and even hypertension. And methotrexate has the potential to affect renal and even hepatic function, and it causes further decline in renal and hepatic functions and should merit adjustments in methotrexate dosing when that occurs. The other options, that is A, C, and D, are all wrong. Let's move to the next question, please. And the next question reads, Mrs. EMA, a 54-year-old female patient with a history of recurrent glioblastoma multiforme, GBM, reports to your clinic where she receives temozolomide. Now, due to an acute asthma exacerbation, she was recently admitted at your hospital. On recovering, she was discharged on high-dose prednisone. So my question to you is, on which of the medications should Mrs. EMA have been discharged? Should it have been diphenhydramine? Should it have been Bactrim, that is sulfamethoxazole, co-formulated with trimethoprim? Or should it have been simvastatin, or a combination of captopril and hydrochlorothiazide? I'll give you 10 seconds to choose the correct answer. She should have been discharged on Bactrim. Now I'd like to start by saying that temozolomide use results in significant lymphopenia, and patients who are on concomitant temozolomide and radiation, or those who are receiving steroids, should get PCP prophylaxis, and you can use sulfamethoxazole co-formulated with trimethoprim in this particular case. Now, steroids may acutely increase the risk of or for higher blood pressure, but antihypertensive prophylaxis isn't recommended at this stage, so I would not settle for D. And then I would just like to add that EMA isn't at an increased risk of hyperlipidemia or even allergic reactions. Therefore, both simvastatin and diphenhydramine are wrong answers to this question. Now, since temozolomide can cause myelosuppression, the absolute neutrophil count, that is ANC, and platelet count should be monitored prior to dosing and even throughout treatment. Just remember that as a by the way. Let's move to the next question, please. And it reads, KPP, a middle-aged cancer patient, develops anticipatory nausea and vomiting as a result of poor antiemetic control. So my question to you is, which of the medications listed below should be initiated or administered in KPP's case now? Should it be ondansetron, promethazine, lorazepam, or dronabinol? I'll give you 10 seconds to choose the correct answer. Lorazepam would be the best option. Now, anticipatory nausea and vomiting is a Pavlovian response from poor nausea and vomiting control, and it classically occurs after several cycles of uncontrolled nausea and vomiting until the patient develops an unprovoked emetic response to the chemotherapy. Now, benzodiazepines are usually administered to help decrease anxiety related to this response, and that makes it the best choice from that list of 4. Let's move to the next slide, please. The next question reads, Mrs. TWG, a 57-year-old female with confirmed ovarian cancer, is scheduled to receive her 7th cycle of paclitaxel and carboplatin. She receives palonosetron, diphenhydramine, ranitidine, and dexamethasone as her premedication prior to her chemotherapy regimen. She received her paclitaxel infusion over 180 minutes ago without any incidents. She developed acute shortness of breath and back pain during the infusion of carboplatin. So my question to you is, which of the statements below best explains the probable cause of this hypersensitivity reaction? Is it a drug interaction between the sequence strategy of paclitaxel and carboplatin, or is it an allergic reaction to palonosetron, or is it acute carboplatin reaction, or is it a delayed onset paclitaxel reaction? I'll give you 10 seconds to choose the correct answer. this is a clear case of an acute carboplatin reaction. Remember, carboplatin is well known to produce a hypersensitivity reaction after 6 cycles of administration of carboplatin. Now, patients who are receiving carboplatin should be monitored closely whenever they receive long courses of carboplatin therapy. I would like to add that paclitaxel almost exclusively produces hypersensitivity reactions during the first or second infusion, not later, not 7th. Now, the reaction with paclitaxel usually occurs during the infusion rather than hours later, so that makes it answer A wrong. And I would just like to add that there isn't a sequencing drug interaction between carboplatin and paclitaxel. Yeah, and I would like to emphasize that this is unlike cisplatin and paclitaxel, which requires paclitaxel to be given first to minimize what we call neutropenic risk. Let's move to the next slide, please. And it reads, Mrs. M.O.M., a 57-year-old female patient with confirmed breast cancer, is receiving her 4th cycle of cyclophosphamide at a dose of 600 milligrams per meter squared, alongside doxorubicin at a dose of 60 milligrams per meter squared. Before her chemotherapy is infused, she dashes to the bathroom to vomit. A few minutes later, she tells the oncology nurse she is now ready to receive her chemotherapy. So my question to you is, what was the cause of this vomiting episode M.O.M. had a short while ago? Is it true that M.O.M. is constipated from anthracycline-induced neurotoxicity? Or is it true that M.O.M. is exhibiting anticipatory nausea and vomiting from her motion sickness? Or is it true that M.O.M. developed anticipatory vomiting from poor antiemetic control with previous cycles? Or is it true that M.O.M. is experiencing delayed emesis from her last cycle of doxorubicin and cyclophosphamide, which was administered 3 weeks ago? I'll give you 10 seconds to choose the correct answer. So M.O.M. developed anticipatory vomiting from poor antiemetic control with previous cycles of chemotherapy. Remember, anticipatory nausea and vomiting is a Pavlovian response from poor nausea and vomiting control, which classically occurs after several cycles of uncontrollable nausea and vomiting until the patient develops an unprovoked emetic response. Now, just like to add that benzodiazepines are usually administered to help decrease the anxiety related to such responses. So those many words justify why C is the correct answer. Let's move to the next question, please. And it reads, which of the chemotherapeutic agents listed below should be taken with food according to the prescribing information? Is it lapatinib, erlotinib, capecitabine, or hydroxyurea? I'll give you 10 seconds to choose the correct answer. Capecitabine it is. Now, according to the package insert, capecitabine should be administered within 30 minutes of consumption of a meal. That's after a meal. Now, lapatinib and erlotinib are recommended to be taken on an empty stomach. The literature is very clear, but the absorption is slightly enhanced when they are taken with food. And I would like to add that there is no recommendation in literature for hydroxyurea in its prescribing information, so that makes D the wrong answer. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share your comments and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in subsequent MCQ series. Thank you.